So I'm going to approach this talk from a different perspective than you probably heard in terms of just experience. Most surgeons who start performing canaloplasty have actually performed glaucoma surgery, or at least since residency. I made the choice not to perform glaucoma surgery after residency, so for 11 years, the only glaucoma surgery that I performed was ALT. So this perspective will be a little bit different, but I think it'll certainly apply to everyone here. So first of all, a disclosure, I am a consultant to eye science. Why didn't I do glaucoma surgery? Well, I think the reasons why we don't like glaucoma surgery are the reasons why I didn't do glaucoma surgery. The difference here is that whether I'm lazy or whether I just have a really, really low tolerance for annoying things, I just found that the risks and complications associated with trabeculectomy and tubes, it's just not something I wanted to deal with. The postoperative hassle for someone who has a busy general ophthalmology office, the idea of filling up my schedule and using up valuable chair time with the postoperative trab patients was just something that I wasn't interested in doing. I couldn't afford to disrupt my schedule with the unexpected, at least not if the unexpected was going to be something that was not only not revenue generating, but was actually going to take away revenue by removing a spot. As Steve mentioned, I'm in Southern California. Our overhead there is exceedingly high, yet our revenue from Medicare, Blue Cross, everyone else is actually lower than in most other areas of the country. So we really do have to be ultra efficient in our area. And then I also benefited from the fact that in Southern California, in the Los Angeles area that I was in, there are plenty of masochistic glaucomatologists. So if I had somebody who needed glaucoma surgery, it was a very simple thing for me to just say, well, I don't do glaucoma surgery. So why did I change my mind? Well, I didn't really change my mind. My patients actually changed it for me. Anyone who's been in practice for 10 years or more discovers one day that your practice is glaucoma. And there's just no avoiding the fact that the vast majority of the office visits have to do with glaucoma. And I had more and more patients who simply wanted me to be the one who treated their glaucoma. They had been with me for a long period of time. They didn't want to go to somebody else. And although it's nice to have academic centers in your area, we're all familiar with what it's like to be a patient in an academic center. Perhaps it's different at yours, but in general, they're there for 3 to 6 hours each visit. And that's just more than some of my elderly patients were really willing to put up with. So my glaucoma surgery volume, now I've already mentioned that it was 0. Well, that was 0 glaucoma surgeries for me. The other reason why I didn't particularly want to get involved with glaucoma surgery is that I knew I'd never get any good at it. Because before performing canaloplasty, I was sending out only 1 patient every month or 2 to the local academic glaucoma specialist. So how would it be possible for me to ever get any good at glaucoma surgery? Well, as I said, my patients convinced me to try something. I thought canaloplasty, being a bleb-free procedure, was something that I could do. The postoperative hassle and frankly, the fear that I had of blebs and the issues involved just wasn't going to be something that I had to worry about. So I thought, well, I'll give it a try. I'll probably never be any good at it. And then my first year, 60 cases. Now, not 110, but then again, I wasn't doing glaucoma surgery beforehand, where Joe was. And my practice isn't quite as busy as yours, I don't believe. But that was surprising to me because I really wasn't pushing glaucoma surgery. Remember, this was in my learning curve, so I was still getting comfortable with it. And even if I was to be pushy with surgery, my general practice in terms of cataract surgery is one where my conversion rate to premium IOLs is only about 7%. So I'm not a very good salesperson. So this growth was essentially an organic growth. This was truly a patient-driven growth in volume. So how have they done? Well, I took a look at the charts of my patients who were at least 250 days out. I had 82 patients to look at. Now, first, one thing that everybody asks about is, well, how frequently do you get the catheter all the way around? Well, it turns out almost 9 out of 10 cases, the catheter was 360 degrees placed. And those patients who didn't get the catheter placed still did very well. Now, of those initial 82 patients, we took a look at those who, to get an idea of what was the pressure about a year out, we took a look at those patients who were 250 to 400 days out when the pressure was measured. And what you see here is the individual pressures of those patients. Now, those two that are actually have a positive change in pressure, those were actually the two eyes of the same patient. And although it looks like this is a failure, this is actually a success. That's only a 3-point difference from pre-op. This patient was on 3 drops, 5 times, well, 3 different drops, 5 drops per day in actual placement in the eye. And after surgery, both eyes were 0 drops. So for her, this was actually a positive effect. This is the actual canaloplasty medications beforehand, the number of medications that patients were on, and then after. And you can see that the vast majority of them have gone to no drops after surgery. And this is the actual number of drops used. And you can see that some of those patients were on quite a few drops per day. This is the phacocanaloplasty. Now, what you'll notice here is that the percent change as well as the absolute change is less than with canaloplasty, but my phacocanaloplasty patients on average started out at about 16 millimeters of mercury as opposed to the mid-20s for canaloplasty. So many of these patients were patients who needed to have cataract surgery but were on multiple drops. So their primary goal was not really to lower the pressure. These patients' primary goal was to get off the drops. So did they get off the drops? Yes, they did. So you can see the drops they were on before surgery and after surgery. So only 2 out of 29 patients were still on any drops. And then we can see what they went from in terms of the number of drops per day. Quite impressive. So what about the complications? Wanted to see whether or not my complication rates were any higher than what we've heard. Well, first of all, hyphema. My hyphema rate was much, much higher. If you look at the first 82 cases, it was 59%, which seems like a lot. But again, as Steve mentioned, hyphema is actually a positive prognostic indicator. 2 independent European studies have looked at this and have shown that the presence of a hyphema after surgery means that you're actually more likely to have a successful result. And it makes sense. You're getting reflux. I actually tell my patients not only about what to expect in terms of their vision, but I tell them that we want to see this hyphema, right? And I'm perhaps a little too convincing because if my patients come in the day after surgery and their vision is identical to what it was before, they're worried. Doctor, did it work? My vision's fine. So this actually doesn't bother me. And if you look at the time to resolution of hyphema, what you'll see is, in general, the hyphema resolves in 1 to 2 weeks. I have had a couple, these were early on, and in general, what people find is that early on your hyphemas are larger, you're not as comfortable with the procedure, it takes longer. My hyphemas now are rarely more than 1 to 2 millimeters in size and almost always resolve by 2 weeks out. So again, this is my early data. How about a Seidel test? We talk about getting that flap watertight. The problem for me in my practice is I have a lot of high myopes, and getting that flap watertight sometimes results in a lot of induced astigmatism. So I try to get it down and opposed, but it's not always watertight. And so I do end up with some positive Seidel tests the first day after surgery, because I'm not doing a mattress suture on the conj, I'm just getting it down, reopposing it. Well, the thing with this positive Seidel test is I have yet had a single patient with a flat chamber. So even with some hypotony, not a single one with a flat chamber. And again, they all resolve. So by 2 weeks out, they've all resolved. How about presence of a bleb? Okay. Now, early on, I have about a quarter of my patients with a bleb. Now, these blebs tend to be low-lying. They're not avascular. They're just some fluid that's getting through, again, because my flap probably isn't watertight. But what happens is they pretty much all resolve. I do have, I don't know why this isn't, I do have 2 patients still out of the 82 who have a bleb, and these blebs are disappearing, okay? And they're not keeping the patients from their normal activities. One of the patients is actually a soft contact lens wearer. She wanted to know whether or not she could wear a contact lens. I said, well, I didn't throw mitomycin C on, go ahead. And her bleb, the next time I give a talk, will probably be gone. How about Descemet's detachments? Early on, I did get a few. I feel that injecting the viscoelastic every 2 clock hours can be aggressive in smaller eyes, and I found that when I was doing that in a hyperopic eye, I was getting a detachment. So I had about a 7% rate, but if I looked at my patients more recently, I don't think that you would see even that high of a rate. So this is another one of those things that tends to become less common with time. How about goniopuncture? We hear about 10%, and in my experience, it's about 11%. What you'll notice with my patients is it could be anywhere. People ask, well, when do you do goniopuncture? Well, looking back, I did goniopuncture all the way from 3 months out, or 2 months out actually, to a couple of years out. So there wasn't really a pattern there. Now, this is a question I get asked a lot, because we know that there's induced astigmatism early on after canaloplasty, and it can be significant. My first patient had 6 diopters of induced astigmatism. But here's the key. It goes away. We looked at induced astigmatism in my patients using preoperative and postoperative Ks, and 250 or more days out, the mean change in astigmatism was just over a quarter diopter with the rule. Okay. How about change in spherical equivalent? Another thing people ask about, thinking, well, that suture in the canal is going to result in some sort of change in the dioptric strength of the cornea. It doesn't. So anyway, that's just a brief summary of my early experience going from somebody who had no experience or skill in glaucoma surgery to someone who very quickly ramped up with canaloplasty. If anyone was set up for failure in this procedure, it was me. All right.